Hello friends, let me take you to a blood pressure variability talk today, and I need to discuss couple of things with you in this video, and it's not very commonly discussed topic, though it's very important. When I discuss that at the end of the talk, you will realize it's so important in day-to-day practice. Now, even when the first blood pressure recording was made by Stephen Hale in the horse, they actually put a large tube, glass tube, about 8 inches, 8 feet and 3 inches long, and he tried to measure the pressure in the artery blood. And when he tried to measure it, even at that time, imagine since 1733 was the first recording of a blood pressure and the very first recording of blood pressure variability. He did notice 3 to 4 inches of variation in the blood pressure while he was taking a measurement over a period of time. So blood pressure variability is there right quite some time. What is blood pressure variability? If you see here, blood pressure varies in the same beat. Yes, it does, because you have a systolic pressure, anacrotic notch, and then you have a diastolic pressure. The pressure in the artery is varying in the same beat. And the blood pressure varies over a period of 5 minutes to 60 minutes in a variable fashion in various people. This is a very short-term BP variability. Short-term BP variability is over 24 hours, what we do in an ambulatory blood pressure monitoring, and the mid-term is over a week blood pressure variability and visit-to-visit blood pressure variability in that patient. And another category of variability is a kind of a blood pressure which is lower in the summers and more in the winter. These are a seasonal variability. So these variabilities do happen at a various frequencies in the body, and that is fine. The variability is okay. What is the importance of this variability? The measurement is that single beat we can measure the variability with a BP instrument, and you can ask the patient to record the blood pressure at home and check for the variability during the day, or one can do is do an ambulatory blood pressure monitoring and look at the blood pressure variability, that is short-term variability over 24 hours or 48 hours period. Then there are new devices which are kind of going to make a scene in the market, which would be able to record variability for a longer period of time. They are called wearable instruments of blood pressure measurement. Very important concept you must understand here is that there are two kind of patients from childhood to the advanced age. Look at the mean blood pressure. Mean blood pressure is increasing in the black line. It is increasing as the age advances. Acceptable. Now there are two patients, one represented with the blue lines and second represented by the red line. Now what we want to say is that the blood pressure in the red line, because a lot of blood pressure variability, it stays on a higher side for a longer period of time than the patient with a blue lines, because the variability is less. So these patients, those who have a higher blood pressure variability, the blood pressure high is going to stay for a longer time. Probably that is the reason why mean pressure, and then you still get an added information from a variability that apart from the mean pressure, the blood pressure remains high for a longer period of time in patients those who have blood pressure variability. Number of studies, I think it's more than 2 or 3 decades we've been listening to these stories that blood pressure variability increases cardiovascular risk, and in this slide you can see it does increase an overall mortality, which is a very important hard point, and cardiovascular mortality in people those who have higher risk of blood pressure variability. Again, blood pressure variability, which is a visit to visit blood pressure variability, the mortality and the incidence of acute myocardial infarction is high in this category of patient, those who have more blood pressure variability. Again, the prognostic significance in this study is shown on a visit-to-visit basis, and we've seen in patients those who suffered TIA, their likelihood of developing stroke in future is higher in patients those who had a high blood pressure variability. Another aspect, that higher BP variability, you have higher risk of developing atrial fibrillation. In quartile 4, where the blood pressure variability is high, there is a higher incidence of developing atrial fibrillation. Blood pressure variability and cause of a secondary cardiovascular risk. Let us say this is the group of individuals who were elderly and about 16,000 patients. Mean age was 75, and these patients had a blood pressure variability. There was a higher risk of developing cardiovascular events to the tune of 1.7 times chances of hospitalization, ischemic stroke. So these patients, those who have high blood pressure variability, have a higher cardiovascular risk. So we have proven beyond doubt that high cardiovascular mortality is associated with high BP variability, apart from the mean blood pressure which is high. So in a patient where your mean blood pressure is high and you have a higher variability, it's an add-on risk factor for subsequent cardiovascular and renal events. These are the events showing that the incidence of hemorrhagic strokes are higher in group of patients which have higher blood pressure variability. So we've understood that not only that, the incidence of cognitive dysfunction, it happens more in people those who have higher blood pressure variability. The incidence of dementia is high, the cognitive functions are lower in patients those who had higher blood pressure variability. So very, very important data that you have is now BP variability related to the arterial stiffness. Now you should know, once you have an arterial stiffness which goes high as the age advances, there is increase in BP variability. Probably you have stiff arteries, and now if the cardiac output varies from beat to beat or during an hour or some change in the cardiac output, immediately as the arteries are stiff, not flexible, the blood pressure would increase. The compliance of the artery is poor. Understood. Now it could be other way around also. We don't know egg first or hen first. It could be that increased BP variability is causing stiffening of the arteries because of the prolonged increased blood pressure. So now at least we've understood controlling mean blood pressure is fine, but we have to go beyond controlling the mean blood pressure. You need to have a mean pressure of 135 averaged over a couple of visits or in the home blood pressure monitoring system. The nocturnal blood pressure should be less than 120, and step 3, which is becoming important now, is that BP variability control is also important. So in that BP control, you have to use a longer acting drugs and the drugs which are known to have a reduction in BP variability. What are those drugs which are known? The longer acting half-lives I have shown for various drugs. Amlodipine scores out of that is seconded by telmisartan, and these medicines have a very long half-life and they reduce that peak and trough variation in a blood pressure and day-to-day variations in blood pressure. Now in this study, we've seen that the BP reduction and the reduction of a variability is an important predictor of a stroke risk in future. So amlodipine scores because it is a long acting drug and it is able to reduce BP variability, thus the incidence of stroke. If we compare amlodipine with other drugs which can have a reduction in a BP variability. The things which come close is a chlorthalidone or losartan given twice a day or a telmisartan. So these two category of, so now what are the drugs which can have a BP variability reduction? Obviously, you have a longer acting amlodipine, you have longer acting ARBs. ACE inhibitor have a short life, should be given twice a day. Particularly, let's talk about ramipril. We have a common culture of giving ramipril once a day. The half life is shorter, it's about 8 hours, should be given twice a day. Chlorthalidone, apart from longer half life, it makes sodium go out of the body and reduces sodium sensitivity of the arteries to blood pressure. So that's why the reason is the BP variability is wonderful. To give you an example, we were wondering in LHAT trial where the chlorthalidone was used, why there was a reduction in mortality over and above other medicines used as compared to that. The reason now we understand the chlorthalidone was a wonderful drug to reduce BP variability and had an impact on cardiovascular mortality and morbidity that time. So same is true, that's what I am saying, that mechanism could be autonomic management. Let's say BP variability in a younger people could be a more related with sympathetic drive, and both in younger and elder people, those who are salt sensitive, it could be related to a salt intake. And if you take care of salt by a long acting diuretic, I think you've done the bit. Now the issue is, we've talked a lot about blood pressure variability, and how do we measure it? What do we tell? What is the cutoff limit? Unfortunately, as of today, we don't have a clear-cut cutoff limit of a BP variability, whether you talk of beat to beat, whether you talk of diurnal, or you talk of a seasonal variability. We do not have a clear-cut cutoff on a variability, and we use various parameters, and that's how we learned it from the various trials done. And they used standard deviation or a lot of other statistical methods to take into account the BP variability. I am going to give you a couple of examples of BP variability. Very few examples, very discrete, and I don't think so you should miss this. This is a 54 years male. He's a senior executive of a company, obviously a lot of pressure day in day out, and detected to have hypertension. And wisely, somebody suggested that ambulatory blood pressure monitoring should be done. All guidelines, NICE, European, American guidelines, Canadian guidelines, they only mention one thing, that it's good to have ambulatory blood pressure monitoring done at least once in almost all patients those who have hypertension. And in this gentleman, we had a couple of findings. It was a normal pressure in the afternoon. You can see this. Okay, this is 5 o'clock until evening. The blood pressure was fine. There was an adequate nocturnal dipping, but there was a marked morning surge. Okay, so now this ambulatory blood pressure monitoring has given us a new insight and a new target to focus, apart from the blood pressure, average blood pressure. Now, if you see in this patient, the minimum was 83, that was the systolic pressure, and the maximum was 214, and these are the standard deviation. That means there was a marked variation in the blood pressure during the day, and even the marked variation at night. So BP variability is there, so we have to choose medicine accordingly. Apart from that, there was a marked morning surge. How do you calculate morning surge is an issue. Do you calculate morning surge based on the immediate before getting up the blood pressure, or you compare with the blood pressure while you went to sleep? We don't know yet, but both methods are fine today. How to calculate the morning surge? In case the blood pressure is more than 10%, we call it a morning surge. Is it important? Look at this study done in 2014, and in this study you notice that's a morning systolic blood pressure, and that means if you have more than 145, this is the morning surge, right? And this is the mean pressure. Look at, if the mean pressure is 150, and if you have a morning surge associated with, look at the mortality hazard ratio. Now hazard ratio is increased if you have morning surge, and it is more important than just high blood pressure. Okay, We know that morning surge is important. It's about 3 times more chance of developing stroke in case we have, and more silent cerebral infarcts in patients those who have a morning surge. I'm going to share with you another interesting patient and the therapeutic implication. Now, a 60 plus female had a non hemorrhagic stroke about 2 months back, and she was referred for ambulatory blood pressure monitoring for a fluctuating blood pressure, what she reported. Look at these figures. You have noticed that the blood pressure falls in the afternoon quite drastically, that it's less than 100 in the afternoon session. Probably she when we inquired, she was taking pills somewhere around 10 o'clock, 11 o'clock, and this is the blood pressure effect of that antihypertensive drug. By evening, because the drug was short acting, by the evening the blood pressure starts rising, and surprisingly there is an increase in blood pressure while she sleeps. So there is a nocturnal rise. So that's a very, very important prognostic parameter. I would tell you what. Now, nocturnal inadequate dipping happens in about, if there is a less than 10% fall in the nocturnal blood pressure from the daytime. Causes are usually, the commonest is sodium overload, obstructive sleep apnea, bad quality of sleep. But stroke, surprisingly, is a very, very important parameter. I'm going to show you in the subsequent slide. And what is the treatment? The treatment of, I'll repeat, the treatment of nocturnal rising or non-dipper is diuretic, because they are diuretic sensitive, they are sodium sensitive patients, and over a period of the day the sodium is collected. At night it has to go through the kidney out of the body, and kidney does natriuresis by increasing the blood pressure. If you have to excrete more sodium out of the kidney would increase the blood pressure to increase the GFR, and then only kidney can excrete that excess of sodium. So nocturnal dosing is another method, but diuretic, a long-acting chlorthalidone or zipamide extended release are the best drugs for that matter. Stroke. About 60 to 70% patients, those who suffer stroke, can have an abnormal nocturnal dipping for about a year or more. So all patients of stroke, please look into the matter whether there is a nocturnal rise or not, because you want to prevent a subsequent stroke, which is quite commonly associated with uncontrolled blood pressure. Another very interesting phenomena, which I think is unusual, I have seen in a couple of patients. This is a lady who was referred for a very, very fluctuating blood pressure. Particularly after meal, she would have a significant drop in blood pressure. Maximum blood pressure systolic was 176, minimum 61 systolic blood pressure. Yes, you heard it right. So now there was a blood pressure variation in pulse, there was a diastolic blood pressure variation, there was a blood pressure variation at night, nocturnal blood pressure. And let's look at the graph. Now, graph shows that she had a meal somewhere around 3 o'clock. And from the blood pressure of about 160, 170, you see sudden drop of blood pressure systolic to about 50 or 40. So this drastical blood pressure fall to a 61 blood pressure systolic is related with meal. This is a new thing which we know, which we call as a postprandial hypotension, very common in elderly. This paper would give you an insight into it. Postprandial hypotension, an underreported silent killer in the elderly, because if the blood pressure suddenly falls below a particular limit, these patients can suffer a myocardial ischemia, cerebral ischemia, and an infarct. The time when the blood pressure has dropped after having a meal, and this is apart from risk of falling and fracturing the bones, right? It is not uncommon. About 1/4 of the patients in the nursing homes, when elderly, age more than 70, would have that, right? And why we have not seen so many patients? very well understood that the mind doesn't know, eyes don't see. They actually suffer from unexplained syncopes and falls. Why does it happen? A sudden increase in splanchnic blood flow, okay, and the heart cardiac output does not rise to that level to maintain the systemic blood pressure. Sudden splanchnic increase in flow because of meal. Second is the reason being increased insulin secretion, which also dampens the epinephrine non-epinephrine response, and it causes vasodilatation. So what do we do in these patients? We reduce gastric emptying. Drugs like acarbose reduce gastric emptying. Drugs like metoclopramide would tend to increase gastric emptying. So don't increase gastric emptying, reduce gastric emptying. Increased gastric emptying would cause something like a dumping syndrome, which you would have in a bariatric surgery or a gastric bypass surgery, where suddenly the food enters the intestine and release of insulin and so many mechanisms causes sudden fall in blood pressure. So same thing happens in these elderly. So gastric emptying should be reduced. Plenty of water, the person should be hydrated. You can space the meal, you can have 5 meals instead of 3. Reduce carbohydrate. In case you do get carbohydrate, should be complex carbohydrates. And coffee before meal has been shown to be beneficial. Somatostatins also have shown some improvement. So this is something good and new, and we should implement. Ask the patient symptoms, because many patients would present with syncope, inability to get up after a meal, or some visual kind of structures, hallucinations immediately after meal. They are related with the cortical hypoperfusion because of hypotension. To end my talk, I would tell you that the world is changing. We know the wearable ECG recording devices, there are many, and now we coming with a wearable device for a blood pressure monitoring. Currently these devices are little bit uncomfortable, and what the devices have, they compress the radial and ulnar arteries, and by they have the cuffs available here, and they can do it on a periodic interval, or we can do it at our own choice. And once the blood pressure recording is done, this can continue for months, and the frequency of multiple day readings can be taken. So this is a new thing which is going to hit the future. Well, we all thought that blood pressure is simple and we don't need to learn more. But of course, some people are still publishing lot of articles, about 60,000 articles in a year. Lot of hypertension conferences are happening. That means their data, which probably we still do not know. And I always learn that, the day I read something, I learn that I still have a lot to learn. And if you still want to learn more, I think it's a good idea to subscribe the channel, so that the moment I publish a new data, new information, new discussion, you would be notified immediately. Thanks for watching this video, and keep watching.